Now, the nice thing about this approach to cranial, and I learned this from the grandson of A.T. Stiles, George A. Laughlin, and he learned it from Sutherland because he was in Sutherland's first cranial course. And during that first cranial course, Sutherland taught him what his grandfather did for treating the rest of the body with indirect functional techniques, but also apparently told him that those principles also applied to the cranial sutures. So remember, one of the sutures we found was if we modified the vault hole and put my second finger on the greater wing and then put my other finger, my first finger now, on the frontal bone, that what you should feel then is with sphenobasilar flexion, you should feel that go a little forward but laterally. And the reason it goes laterally, because as the temporals take the greater wings laterally, the frontals are sitting on that, and that carries them laterally, so then the frontal bones go into external rotation. So if that suture is dysfunctional, you can easily get access to it. Now, one of the nice things about this cranial approach is there are only two techniques. One for sutures that are superficial and you can get on either side of the bone. And the second is for deep sutures where you can't get on either side of the bones, but if you use the two bones that make up the suture, you can get the same effect. So to treat, and why this suture is so important, it's L-shaped. And it correlates with the L-shaped articular surface of the sacroiliac joint. And wouldn't it make sense that if you have a long dural tube, that you would want a comparable joint on either end of that dural tube? So frequently, when this suture is dysfunction, the patient will complain of pain in that area and headaches, but they'll also complain of low back pain. And many times as you treat a low back effectively, the patient will say, I don't know what you just did, but you got rid of my headache, and they'll point to that area. So to treat that, you can get a thumb on either side of that suture, and then you blend in with those tissues just real gently. And then ask yourself which of the bones is moving, has the least amount of movement. So if it's the greater wing, then what you're doing is you're not introducing a force or pushing a bone. You're like making an offer. So you're like saying, will you let me glide you forward? And if it glides forward, then go with it. If it doesn't, say, will you let me glide you posterior? And if it glides posterior, just go with it. Then hold that. Will you let me glide inferiorly, caudad? No. Will you let me go cephalad? Yes. Stack that on top. Then say, will you let me go counterclockwise or clockwise? Say in this case clockwise. So then you hold those three movements there, and many times as you get in that position, you'll be able to feel that bone start to get the normal flexion extension movement pattern. Then take the other bone, the frontal case, and say, make it an offer. Will you allow me to glide you forward? No. Will you allow me to glide you back? Yes. Will you allow me to glide you cephalad? No. How about caudad? Yes. How about clockwise, counterclockwise? And again, take it where it wants to go in three planes. So what you've accomplished is you've loose packed the two bones that make up the suture. You've loose packed the suture. I think you've balanced up the reciprocal tension membrane associated with that suture. And then that can have a profound effect on the reciprocal tension membrane throughout the cranium. So that's why, although you're treating very locally, you can have a profound effect. Then you just gently put a little compression into that suture with both thumbs. And do it very gently, and when you get the right amount in, the two bones will just start moving and unwinding, and one bone will move more than the other. Lots of times they'll switch back and forth, and then frequently what happens is they compress in, and then hold it stops for a few seconds. Keep your pressure there, and then what that thing will do is just open right up. And that would be the ultimate in a frontal lift technique. And also think about that when you do a V-spread on a technique like that, then you're assuming that just needs to open up. Whereas many times for these sutures to release, they've got to become almost exaggerated and compressed in a little more, and then they open up. So that would be the first hole. The second hole is common, is the greater wing zygoma. And how did we say we found that? We had a second finger on the greater wing, and when we checked the zygoma here, there was no movement, or if you just spring it a little bit, it'll feel hard as a rock. So that tells you it's the zygomatic greater wing suture right in here. And those are the people that many times come in and say, they'll point to that side of the head and say, I get a headache and it seems like it's almost in behind my eye. Well, look at how far back that's in the orbit. So to treat that again, we can get on either side of that suture. So one thumb is going to be on the zygoma, one thumb is going to be on the greater wing. Blend in with the tissues. When you do, ask yourself which one is most restricted. Make it an offer and take it where it wants to go. Take the other one where it wants to go. Again, you've loose packed the two bones, the suture, the reciprocal tension membrane. Then slowly put in a little compression into that suture, and when you do, one bone will start moving or the other will move, or they'll both start moving, then maybe one will stop and the other moves, then it stops, and it can go through all sorts of different patterns like that, but then all of a sudden it'll stop and it'll just open right up. So then you know that you've got that suture. Now another common suture we said was in the vault hole. See, and what's nice about the vault hole, Kimberly used to like to stress, that it's the only hole that you can monitor simultaneously the sphenoid, the occiput, and the temporals to make sure those bones are going into flexion extension properly. And if the temporal isn't properly moving and you feel most of the restriction in the screen between these two fingers, remember we said that would be temporal greater wing. Well, many times if you palpate along there, you'll feel a real hard spot in that suture. And that's probably where their SS pivot point is. And again, if you get on either side of that, ask yourself which of the two bones is most restricted. Make an offer to find the balance point for one, the tightest one, then the other one, then put a little compression again, and they will unwind. So see what we've done here. We've worked through the SS pivot point, the greater wing frontal and greater wing zygoma. Now, another common problem will be, and why the greater wing zygoma is important, is Sutherland had nicknames for bones, and a lot of times he didn't explain what he meant by it. But he said the zygoma and the palatines, he called them speed reducers. And I could never find what he meant by that. And the dental group that I worked with, we came to the conclusion was that the vault bones are supposed to have quite a bit of movement in them, but there's not supposed to be a lot of movement in the facial bones. So the job of the zygoma and the palatines is to absorb a lot of that movement so it doesn't go into the facial bones. And if the zygoma gets dysfunctional, or the palatines, that can put a lot of movement now into the facial bones. And these people have crazy facial patterns of pain that the neurologists can't figure out, the ENT people can't figure out, the dentists can't figure out, and you get those sutural dysfunctions out, and the patient says that you've relieved their facial pain. So that's a very, very important suture. Now another suture that's easy and frequently restricted will be the coronal suture. And why that's so important is because remember the homunculus is underneath there, that area of the brain. And remember the homunculus is the motor and sensory representation in the brain of the total body. So the butt is in this area, the legs go in, the rest of the trunk comes down, hand and face are down in here. So don't be surprised that when you find a coronal sutural dysfunction, that if you palpate along that suture, you'll find a hard spot in there. And many times, like particularly with TMJ patients, you'll find a lot of dysfunction in this area here, which is going to be the area of the homunculus for the TMJ and joint and jaw. Whereas if a lot of the dysfunction's up in here, many times that correlates with the patient with low back pain. So to get that, find the hard spot in there, then get on either side, blend in, ask yourself which bone is the most restricted, take it to its dynamic balance point by making it an offer in cephalad, caudad, anterior, posterior, clockwise, counterclockwise. Hold it in that most balanced point, then do the other bone. So again, you're loose packing the two bones, you're loose packing the suture, and you're balancing up the reciprocal tension membrane locally, and I would maintain systemically in the cranium. So then just put a little compression in, and when you put the right amount of compression in, the bones will immediately start to release and the suture will start to release. And when the pressure's right, if you close your eyes, you'll swear you're not touching that patient because you're not pushing the bones aren't pushing you, you're just blending in with those bones and it's like a dance. And don't be surprised if they move around, stop, and then just open right up. Now, the other treatment is for deep bones that many times can be really crucial in treating patients. And one of the key areas is, remember we talked about in our cranial screen with the vault hole, if we felt most of the dysfunction between these two fingers, it meant it was petereus. And if it was the finger more in front of the ear, it was going to be petereus sphenoid suture. And if it was more the finger behind the ear, it's going to be petereus occipital. Well, look at that. If it's petereus occipital, that's going to affect the jugular foramen, which can markedly affect the 9th, 10th, and 11th cranial nerves and affect the vagus. And remember, that can either stimulate or inhibit that vagus. So don't be surprised if you find this sutural dysfunction with asthmatics, because that can be stimulating the parasympathetic, the vagus, and causing the bronchial constriction. So to treat that, there's no way you can get your thumbs in on either side of that. But if you palpate the mastoid process and get your fingers around from the other side to get on the most lateral part of the occiput, then ask yourself which of the two bones is most restricted. Take it through making it off again to where its dynamic balance point is in anterior, posterior, medial, lateral, clockwise, counterclockwise. Then do the other bone and put a little compression in there again. And don't be surprised if you can see a tremendous change in that. And don't be surprised if you see big changes in the autonomic nervous system. Now, Becker talked about sometimes when you treat the mastoid suture, the occipital mastoid suture, that you get a violent vagal response to that. And I think the reason was that those people, it was more occipital petereus, and when you just treat this, you don't get in deep and get the petereus occipital, and I think maybe that's why Becker noticed that sometimes you get an adverse response to that. But you can be affecting in there way deep. Now, the other one, remember, we said if the finger in front of the ear, it would be petereus sphenoid. Well, again, you can't get a finger on either side. But if you grab the mastoid process, that'll allow you to control the petereus portion of that suture. And then if you get your fingers on the greater wings, the thumb on the greater wing and a finger on the greater wing on the other side, and again, ask yourself which of the two bones is most restricted. Find the balance point for those two bones. Put a little compression into that suture. And why that suture is so important is because the tip of that petereus portion is right in the carotid canal, where the carotid vessels are going into the head and bringing the sympathetics into the head. So don't be surprised if that suture is dysfunctional in people that have vascular headaches. And many times, as they're having a vascular headache, if you treat that sutural dysfunction, that headache will quiet down beautifully. So we talked about those two sutures. Then the other one we want to do that is a common sutural dysfunction is the SS suture right here. So it's the squamous sphenoid suture. And when you look at a disarticulated skull, because when you look at the bones from the side, you think, oh, they're going to be very thin bones. But that suture, I've measured it in all sorts of human skulls and in the plastic skulls. And on the sphenoid side, that is about 4 millimeters in width. And you wonder, why is that suture that wide? And because if it was very narrow, then temporals could have a tendency to slide either in front or in back of that the sphenoid. Whereas because that's 4 millimeters wide, that allows the temporals to rock into internal and external rotation. So if that suture gets dysfunctional, boy, that can really affect sphenobasilar flexion extension. It can affect temporal, internal, and external rotation, and it's a very common dysfunction with the TMJ patient. So to treat that then, if we get on a thumb on the greater wing, that's going to be controlling the sphenoid side. Then if I pinch the zygomatic arch right close to the temporal bone, that's controlling this side of the suture, the temporal side. And again, I'm asking myself, which of the two is most restricted? Take it, making it an offer to its balance point. Then the other one, do the same thing. Then put a little compression between your two thumbs into that suture, and then that suture can start to unwind. And again, don't be surprised if they compress in and then if they open up. And so you're basically using an indirect approach to get to that. Now, the last suture I want to discuss has been an amazing one for me. And what it is, it's the frontal lesser wing suture way back in the orbit. And when that suture gets locked up is when there's a blow to the front of the head. And many times when you get that blow to the head and it locks that up, naturally it's going to affect the frontal area, so they can have cognitive things, can have issues learning, studying, concentrating. They can feel like they're in a fog. They frequently say, I have a headache, and they'll put their fingers across the frontal area and say, my headache is right across here. And then it can affect the interorbital fissures, so it can affect many of the muscles that go into the orbit, so it can affect vision. So that's why a lot of times they can say, I'm having trouble focusing, and I have unbelievable headaches. And so frequently they're told, especially if they've had head trauma, that they've had a concussion. And I've seen more patients who have been told they had a concussion, had weeks or months of post-concussion syndrome. When I screened out the head, found that it was that lesser wing lesser wing frontal suture. And once that was released, then immediately they said, it's like someone turned the switch on. My brain's functioning now. It's clear. I'm not in a fog. My headache is gone, and I can focus a lot better. So obviously, you're not going to get a finger on either side of those sutures. But if you get a hold of the frontal bone, how is the best way for you to blend your fingers in? And you want to try to have as much contact right in this area, because that's what's been driven back. And then with and sometimes I'll just use my thumb to get on there. But then get a hold of the greater wings. And so then what you can do is, if you got the two bones that make up that suture, you're impacting that suture. Then if it feels like the frontal's most restricted, does it want to go laterally, left or right? Does it want to go cephalad caudate? Does it want to go clockwise, counterclockwise? Then do the same thing, making an offer with using the greater wings of the sphenoid. And many times as you're doing that, the patient will say, boy, it feels like you're working way deep in my head, way back behind my eyes, which basically what you're doing. And like I said, I've had many people who have been told they had a concussion right after an injury, and if you could treat that as soon as possible after, it would clear right up. Well, if they had a concussion, the symptomatology wouldn't clear that fast. So what we did is, then we've demonstrated today how you could do a screen, find the key suture. Then the good news is there's only two techniques. One is for superficial sutures, where you can get on either side of the bone and balance those up and put it in a little compression. And then if they're deep sutures, then you get a hold of the two bones that make up the suture. Then you're working in deeply into that suture. The other thing is about the compression I was talking about. How I learned about that was from Roland Becker. And one time at a meeting, he got up and he was saying, sometimes you've got to put a lot of force into a head to release traumas when they've had a lot of trauma to the head. And when he came down off the stage, I said to him, Roland, I'm glad to hear somebody's finally admitting that sometimes you got to use a lot of pressure, because most cranial people teach you use real light pressure. And I said, I want you to get a hold of my head with a vault hole and see, I want to feel what it feels like when you put the right amount of pressure into my head. So I said, you tell me when you got the right amount of pressure. And when he said now, I thought, he's not touching. I had my eyes closed and I was trying to picture in my mind what was going on. And I thought, he's not touching me. And I rapidly put my hands up and checked, and sure enough, he was palpating my head. And I said, how much pressure are you using? And he said, a lot. And I said, but it didn't feel like you were doing anything. And that's when I realized that when you've got the right amount of pressure, even though you're putting a lot in, you're not pushing the bones aren't pushing you, and it can feel like real light pressure. And we confirmed this in a way with Brian Degenhardt in doing some research on cranial in Kirksville at one time when they tested how much pressure we were using to get in patients' mechanisms. And they said my pressure was so light that the machinery and the equipment wasn't sensitive enough to pick it up, and said my pressure was very, very light. But I was putting in a lot of pressure. So it showed that when I got the right amount in, the system and the equipment said I was putting in real light pressure because I wasn't pushing the bones weren't pushing me. So compression is right, and how you know you got the right amount is when you slowly put it in. If you just close your eyes, you'll swear you're not touching those two bones because you're not forcing them, and the bone's not forcing against you. You're just blending in. It's like a dance.